So the article I'm citing is from the May 2nd issue of JAMA, where we have an article by Dr. Loken, colleagues talking about the effect of fish oil supplementation on graft patency and cardiovascular events among patients with new synthetic AV hemodialysis grafts. So, a little bit of background about this. So, amongst hemodialysis grafts in the United States, and this is from the USRDS database from 2010, we have 55% of the patients having fistulas, which goes along with our fistula first program in the States, 21% of the patients with AV grafts, and another 24%, unfortunately, with tunnel catheters. So, here's a single study center trial that kind of puts things in perspective. Since one out of five patients on hemodialysis has a graft, it looks like this study looked at 256 grafts placed at a single institution over a 2-year period and looked at salvage procedures to maintain graft patency. That included thrombectomy, angioplasty, or surgical revision. 1/3 of them needed some type of intervention at 3 months, half of them at 6 months, more than 3/4 at 12 months, and almost 96% at 2 years needed some type of intervention. So keeping these things open seems to be uh, takes some maintenance and takes a little bit of cost. So there's been many studies and approaches out there. We have looked at antiplatelet, anticoagulation agents, and here's a nice review article that looked at clozapine, dipyridamole, aspirin, the Agranox combination pill of dipyridamole and aspirin, and warfarin. Now, these have been shown to reduce thrombosis rates without increasing bleeding risk, but no change in graft survival. So there was more, the risk versus benefit did not help out. So why are we talking about fish oil now? Now fish oils are the fish oils are antioxidants, vasodilatory, antiproliferative, which we know from many cardiovascular trials. So let, the the authors of this trial did do a design of fish oil inhibition stenosis and hemodialysis grafts study that was published, which proposed this. So some background from some basic sciences studies in the 80s showed that omega-3 fatty acids do reduce platelet aggregation in patients receiving hemodialysis. Patients have decreased serum viscosity in peritoneal dialysis patients, and then inhibition of the neointimal hyperplasia, which is the main cause of AV graft stenosis. So we can look at this study, which is which was one of the hypotheses behind the article we're looking at. 24 patients at a single center looked at perspective, and this was amazing, the results of this study, showing that the fish oil group had significantly less interventions than the group that was not given placebo. But then again, there was only 12 patients per group. So another trial was done, and this was using fish oil at a single center trial. Same amount of patients, 29 versus 24, and they used the new loop forearms, and this was prospective. But there was no difference after 8 months of follow-up in graft patency. But now notice the EPA and DHA doses, which were a little different. So the study we're going to talk about was funded by the two peer-reviewed Canadian funding agencies. IRBs and safeties were all done. Written consent was taken from all patients enrolled in the study. People who were enrolled in the study, all of them had to be 18 years or older, on end-stage kidney disease on chronic dialysis, and they required a synthetic AV graft. AV graft could be either first access or subsequent access after previous access has failed. Of course, they could not have had a previous failed AV graft. Other exclusion criteria was they couldn't be enrolled in another study of hemodialysis access, allergies to fish or fish products, life expectancy less than 6 months. They could be on aspirin or warfarin, but they could not be on more than 2 antiplatelet or anticoagulant agents. could not be pregnant, could not have uncontrolled hypertension, did not have a major bleed within the last prior month of having AV graft placement, active malignancy, or reversible kidney failure. So 12 sites in Canada and 3 sites in the U.S. were used. The enrollment period was from November 2003 to December 2009. Patients were followed over 12 months after the creation of the AV graft. Patients were randomized 1-to-1 into 2 treatment groups. On post-op day 7, either patients were on 1 gram of fish oil 4 times a day or placebo 4 times a day. Placebo contained corn oil and was packaged identically and shaped identically and colored identically, and both were flavored with peppermint to have identical flavor, so no one could tell them apart. The fish oil that was used was made by Ocean Nutrition Canada. It was called MEG3, and it had an EPA content of 1.6 EPA 400 milligrams per pill and 200 milligrams of DHA, which is actually higher than if we go back to the previous slide of this study. So the doses were significantly higher, so we can see if that makes a difference as well. And we also know that a lot of the over-the-counter fish oils have to be metabolized into EPA and DHA, and unfortunately a lot of hemodialysis patients are not able to do that. So it was a good thing they used these pills that had metabolically active fish oil. So all patients, study coordinators, caregivers, and site pharmacists were blinded to the treatment. Only the study independent pharmacists who packaged the pills had access to which pills were randomized. Patients were followed on a twice-a-week basis. All sites abided to local graft surveillance protocols, and the participating study sites could not change their policy or surveillance during the study time period. Now, most of the Canadian sites use the Canadian National Guidelines, which was when the graft flow decreased to more than 20% from baseline or decreased to 650 of blood flow, an angiogram was done. An angiography showed stenotic lesion greater than 50%, then angioplasty was attempted. Angiography without subsequent intervention was not considered an endpoint. So angioplasty, stent, and revision were all were considered endpoints. So compliance was assessed using the EPA level in the endothelium. Baseline EPA levels were done prior to the study, which showed no difference. So you had the enrollment group, and you had 201 people, 101 in the treatment arm, and 100 in the fish oil group. So the primary endpoints was defined a proportion of AV grafts loss of native patency within the last 12 months. Now, native patency was the graft having a thrombosis requiring radiologic or surgical intervention to maintain patency. Major secondary endpoints included rate and proportion of AV thrombosis, radiologic and surgical interventions, time to each event, and cumulative graft patency. So you got the patient demographics and baseline. So you can see good equal number of whites, blacks, South Asians, and East Asians. Same equal number of diabetics, GN, hypertension, and the only difference actually was the CHF patients were increased in the fish oil group. And one thing is interesting to note is that both sides were on lipid-lowering agents. Both had similar levels of cholesterol. Aspirin and warfarin and clopidogrel were about equal in both arms. So more patients had CHF, as mentioned before, in the fish oil group, and we all know that CHF has increased risk and incidence of thrombosis in all hemodialysis access. And more patients in the fish oil group had a forearm graft, but this was found to not be statistically significant. So the primary endpoint, there was no significant difference in the proportion of fish oil recipients and placebo recipients with the loss of native patency. So it was 48 versus 60, which is a p-value of 0.6. the rate of events was lower in the fish oil group compared to the placebo group, so it did trend towards the fish oil group. So we look at the results. Sorry, this did not come out as well as I'd like, but we'll go into it a little bit. The frequency of loss of native patency, thrombosis, and corrective interventions reduced in the fish oil group. The 12-month event rate was 48% in the fish oil group and 32% in the placebo group. So it did seem that the fish oil group did do better in the secondary endpoints of these, and there was no loss in native patency of the AV grafts in either group. So both groups continue to have patency, even if they had to have different types of procedures. Cumulative graft patency was not significantly different at 28% in the treatment group and 35% in the placebo group. There was no differences between study sites, no difference of the first access or subsequent access. So we look at some of these graphs. You can see primary events much higher in the placebo arm, thrombosis higher in the placebo arm, interventions higher in the placebo arm. Cardiovascular events seems to be statistically not significant, but trending towards the official arm having less cardiovascular events. Now, we look at these Kaplan-Meier curves, and you can definitely see the time to loss of graft patency definitely works for the placebo arm. These patients definitely kept their grafts longer. Time to intervention, the official arm definitely had a longer time before they needed any type of intervention. Time to thrombosis, again, longer time for the official arm. And time for cardiovascular events was longer for the official arm. So this did show some type of significance that the official arm did have a longer time before they ended up needing any type of intervention. Systolic blood pressure was lower in the treatment arm at the end of 6 months of therapy and was sustained for the entire 12 months of the study. So less blood pressure medications were required in the fish oil group. But there was also no difference seen in the serum levels of cholesterol, LDL, or triglycerides between both groups. There was no difference in the bleeding events between both groups. Loss of native patency in the AV graft was statistically significant between those who received fish oil and those who did not. However, the study group was underpowered. Would a larger study group yield a difference? I don't know. Is this something worth studying longer about? Also, fish oil recipients had a longer time without thrombosis, half the thrombosis rate, and reduced rate of interventions. Is this enough to change our practice? Also, improved cardiovascular events and decreased blood pressure in the fish oil group. Leading cause of death in ESRD patients is cardiovascular events. It did not change the lipid profile in our ESRD patients. Should we further study fish oil in all our ESRD patients, seeing this outcomes of the SHARP data, 3D study, and all those? Do we need, in the 4D study, do we need to look at that, seeing that statins don't seem to be as effective in ESRD patients? And grafts may require many more interventions and more complications than fistulas. In the era of fistula first, should we trying to expand graft function? And I actually think we should be, because 1/5 of the patients still use grafts, and there's a lot of patients who fistulas just are not compatible for. But this article really does open up more questions and answers fewer. But we should stay tuned, because the FAVOR trial is coming out soon, and this is going to be 1,200 patients with either graft or fistula, evaluated with both fish oil, aspirin, and or both for patency of access and follow-up time of 36 months. So we should all be looking forward to this study coming out. Thank you very much, and have any questions and to add to the conversation, please go ahead and do so.